Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Today's topic is ADHD diagnosis, what you and your doctor need to know. We are fortunate to have Joel Nigg with us, who will explain the ins and outs of an accurate diagnosis. A solid diagnosis is absolutely key to getting the right treatment. Dr. Nigg is professor of psychiatry, behavior neuroscience, and pediatrics at Oregon Health and Science University. He is the author of the highly reviewed book, What Causes ADHD? Dr. Nigg will give some introductory remarks about ADHD diagnosis and then take your questions. So, welcome, Dr. Nigg, and I turn it over to you.
Thank you, Wayne. Thank you, everyone, and welcome. I'm going to begin by just giving some fundamental review on ADHD diagnosis, and I'm going to then move on to some immediate questions and controversies about diagnosis, and then we'll throw it open to questions from the audience after about 10 minutes or so. First of all, the key elements of a diagnosis, I just want to walk through these and make sure everyone is aware of them. As Wayne alluded to, it's important to get the diagnosis right. Sometimes people underestimate the importance of actually doing the diagnosis of ADHD, and I just want to highlight that it can be a problem to either fail to make the diagnosis or to make the diagnosis incorrectly. Failing to spot it can lead the child to, or the adult, to unnecessary poor outcomes that could be prevented or improved. And it can also mean failure to access needed services. On the other hand, we obviously don't want incorrect labeling or identification of children because that can also cause its own problems. There's 3 or 4 key elements and 1 or 2 frequently advisable elements to an appropriate diagnostic evaluation. The first element is the clinician has to conduct a detailed history. And this is vital because there are so many both medical and psychological mimics for ADHD. The condition can be imitated by any number of other problems or conditions. These include a history of trauma, mood disorders, or developmental delays. It also includes a laundry list of medical and metabolic conditions. The appropriate evaluation should have multiple informants, and the DSM-4 and DSM-5 have both emphasized this, and the research literature also shows this, that your accuracy of diagnosis is much, much higher if you have input from 2 independent informants who have seen the child in different settings. In the case of children, this is typically parents and teachers. 2 parents are not quite as good because the 2 parents often are seeing the child in the same setting, although if you cannot get a teacher, at least getting 2 parents is an improvement. Thirdly, it's extremely important to use standardized or normative ratings. These greatly improve diagnostic accuracy. They're low cost, and these include standard scales like the Conners Rating Scale, the Child Behavior Checklist, the Strengths and Difficulties Questionnaire, the ADHD Rating Scale. There are half a dozen of these that are well-normed and provide similar information. Parents and teachers can complete these, and clinicians can score them and determine what the probability is that the child is in the extreme range compared to national averages. Often, medical checkup is advisable, and again, this is because of the frequent medical imitators. For example, thyroid conditions, sleep disorders can mimic ADHD. And finally, in some instances, and I notice this is already a question a number of people have asked, psychological or neuropsychological evaluation can be advisable. Although, and I'll talk about this in a minute, these tests are not going to be diagnostic per se. They can really help to provide additional ancillary information, and in particular, guide the treatment planning by identifying nonverbal learning disability or learning disability, a particular learning style that is going to be particularly helpful for this child, and in some instances, it's also identifying additional psychiatric problems. There are some changes in the case of adolescents and adults that have to be brought to mind. In particular, for adolescents, there are risky behaviors that increase in relation to ADHD. I've listed some here: driving accidents, risk of drug use is increased, risky sex, spending decisions. these kinds of risky behaviors become a particular hazard for individuals with ADHD, and the clinician has to take these into account in determining the importance of intervening and the level of risk for the individual. In the case of adults, some of these same risks occur. In addition, for adults, some of the symptoms on the symptom list are not really suitable. For an example, the DSM lists a symptom of running around the room outside of their seat. This is something that adults, even with ADHD, don't do, and so the clinician has to adjust to look for extreme restlessness and other modifications for adults. And these modifications are described to some extent in the DSM-5 text, but there are not separate criteria formally provided for adults, and the clinician has to adjust to this. This is a limitation of the DSM. And then finally, childhood history is very important in making the adult determination, because we want to know that this is a condition that's been chronic for this individual and is not something that has just recently started, which would lead to a very different picture clinically. But getting that childhood history is very difficult. None of us are as accurate in recalling our childhood history as we like to think, and it's very valuable, if possible, to get an ancillary informant. Although that's not always possible, it's desirable in every case. A common question that Wayne in particular asked me to talk about is adjunctive measures, and there's a number of adjunctive measures that have been proposed for diagnosing ADHD. These include cognitive measures like the Continuous Performance Test, the TOVA, or the Conners. And recently we've seen a lot of media interest in brain imaging measures as adjunctive measures. So I'm going to spend a minute explaining this because it's been such a common question recently. And first of all, I'll say there are lots of high hopes for mechanical or neuroimaging methods for diagnosis in ADHD. Tremendous amount of progress on technology here that drives these hopes. And certainly all of us share the hope that we will be able to get better biological or objective or biometric measures as we go forward. Recently, the FDA approved a method using EEG or brain imaging measures. The punchline here that I'm going to conclude with is that I'm not convinced these are cost-effective measures in most instances, but to tell you why I think that, I'm going to walk through these data so you can be informed of what exactly has been proposed and argued here. So the method that was recently in the New York Times, recently approved by the FDA, is a method using EEG. That stands for electroencephalogram. And this involves putting electrodes on the scalp and detecting electrical signals from the brain. These electrical signals can be decomposed into different waveforms, fast and slow waveforms. And the most popular method here is to use what's called the theta-beta ratio. This is simply the ratio of fast to slow brain waves. And it's a way of indicating the level of alertness or the level of cortical arousal in the brain. There's been a substantial literature pursuing this as a biomarker in ADHD. And this particular company called Nigg recently obtained FDA approval for their version of this and developed a test that, as far as I can tell from studying this, is about a $300 test, not currently covered by insurance. And the claim from the company is that this will incrementally improve the diagnostic accuracy as part of an overall evaluation. So they're not claiming, appropriately, they're not claiming that it's a standalone diagnostic test, but they are claiming it would improve diagnostic accuracy. And you can read their report at the web link that I provided here. This is not a peer-reviewed publication. It's data that they developed in a trial and submitted to the FDA on 275 children that they obtained. And I'm just going to walk you through briefly what they reported here that made the FDA decide that it was okay to approve this test. They had clinicians try to diagnose ADHD in a standard way, and what they reported is that the clinicians were very accurate in identifying ADHD. As you can see here in the first point on this slide, almost 90% of the cases with ADHD were correctly picked up by the clinicians, but the clinicians also had a tendency to over-identify ADHD in kids who did not have ADHD. This is called low specificity. For example, if a child was sleep-deprived or depressed, the clinicians were tending to call this ADHD. That's a common source of error or concern. The Nigg company reported that when their theta-beta test was added to the battery, the identification accuracy changed. The clinicians actually were less accurate in picking out ADHD cases, dropping to about 80%. However, their false identification rate, false positive rate, was much reduced, leading to better overall accuracy. And it's kind of in small print here, you can note under that second point that those cases that were wrongly identified by the clinicians as ADHD were frequently those where the teacher ratings were not supportive of ADHD, and this underscores my earlier point about the importance of cross-informant convergence, teachers and parents, for the clinician to evaluate. And a second point, a third of those that were falsely identified by the clinicians had vision or hearing problems that had not been detected, and this goes back to the importance of a basic medical checkup before getting too far down the road of ADHD. Overall, these results were seen by the FDA as improving, being safe, low risk, and somewhat improving accuracy. All right, so why am I not enthusiastic? Why am I suggesting caution? Well, here are some cautions. First of all, there was no cross-replication of these data. This was a one-time report with an unusually high accuracy rate. There's been half a dozen to a dozen studies like this in the literature that have been peer-reviewed, and they were reviewed recently by Arns, Connors, and Kramer, and I provide that citation here so you can read that review. And they did see a few studies that saw these very large accuracy levels like what Nigg found, but most studies were not that accurate. And when they pooled across all studies, these effect sizes here, what I'm showing you, these are just technical numbers for your reference, but the reason I mention these effect sizes of 0.75 and 0.62 is that these are effect sizes that suggest a high overlap between ADHD and non-ADHD children, overlaps that would provide about a 50% error rate on these tests. And the reason this is important to point out is that this is similar to most other tests that already exist, like this Connors Continuous Performance Test or the TOVA Continuous Performance Test. All these tests have similar effect sizes and similar error rates when they stand alone, and all of them can therefore provide a little bit of incremental accuracy to the clinician when needed. This suggests that the accuracy level of this test is probably going to be not as high in daily practice as it is in the single report to the FDA, and also that this test probably performs exactly the same as a lot of other tests that already exist. Therefore, this type of adjunctive test, I continue to feel, can be helpful in some instances, but there's nothing special about the EEG test or the Nigg test. It's just another test similar to others that already exist. Not a breakthrough in my mind because of the method and the literature that goes with it. However, I want to draw your attention to the final point that I've made on this slide, which is that these adjunctive tests, things like a continuous performance test or an EEG brain scan and these sorts of things, these seem to be holding more promise in the literature for predicting treatment response than for diagnosis. And so even though I'm conveying to you some skepticism about the value of these for diagnostic purposes, I don't think that they're a waste of time, and I think there's going to be a future for these tests when it comes to predicting treatment response and deciding what treatment to use. So my message here is stay tuned. It's not time to go real extreme about these tests yet, but we may see some pretty interesting results going forward. This last slide is just a picture that illustrates the high sensitivity, low specificity picture to help you visualize this. This is very commonly the picture for clinicians and tests, and the colored-in circles here represent the errors, and it just allows you to visualize that your failed test and your successful test error rates, so you can visualize that. But given that I've already gone 15 minutes here, I'm going to conclude and open this up to questions. This is an overview, and we can go with audience interest from here.
Okay, thanks. Plenty of questions. I'll start out with a general one. How should a parent or an adult prepare for an evaluation or diagnosis? What should you think about before going to the doctor's office, and should you bring any reports or information when you see the doctor?
It's a great question, and it's really helpful to the doctor if the parent does do some preparation. I would do I would advise parents as a general rule to do the following. Number one, go ahead and get that medical checkup. Make sure your regular child's doctor knows you have these concerns and does not see an obvious medical cause. Number two, take some notes about exactly what behaviors you're really seeing. The first thing a good clinician will ask you is exactly what behavior did you see, when does it occur, how long does it last. The more precise you can be, the more rapidly you'll come to a correct answer with your clinician. And the third point that I would think about as a parent prior to going for the evaluation is I call this kind of mental health hygiene or alertness hygiene. Is my child getting adequate sleep? Many parents and even clinicians are not aware of how much sleep children are supposed to have, and we've seen some literature that children's sleep has dropped in the last 20 years across the board. So is my child, depending on their age, getting that 10 hours or 11 hours or 9 hours that they should be getting for their age? Secondly, are they eating well? Thirdly, are they getting enough exercise and playtime? And fourth, is there an emotional climate of high stress in the home that might complicate the picture? Doesn't mean you shouldn't go for the evaluation, but be honest about that, and your clinician can help you think about how to factor the home stress level into the picture. Sometimes that stress level, of course, is caused by the problems the child is having. Okay, I'll go to the next question.
Would the advice be the same for an adult who's going for an evaluation, or be slightly different there?
It would be largely similar. I think for the adult, then there's some introspection required. And again, it goes to lifestyle. Am I using any substances? Am I cutting corners on my sleep? Is this really me all the time, or is this an unusual phase that I'm in? Just really thinking through your history carefully, that you can not be going off the cuff, but really have thought about specifics in your life. When have I really had these problems before, and has this really been enduring, or am I just thinking that now? So that introspection and specifics can really help. But other than that, I think that the advice is largely similar.
One viewer asks, is just having a pediatrician diagnose ADHD enough, or should I get a second opinion of a child psychologist?
That's a great question, and it's a tricky one because in reality, pediatricians are doing the lion's share of the heavy lifting here by necessity because there aren't enough psychologists. I would say that it depends on the pediatrician. Some pediatricians that I know have a lot of experience with ADHD. They're able to take the time to do the appropriate history and rating scales and make a good judgment. Others just don't have the time or the experience to really get the full answer that you want. And the good ones that I've seen recognize this, that they haven't seen enough cases or that don't have time to do the full evaluation. So it's a combination of, can the pediatrician give you that lengthy evaluation that you need, and have they seen enough ADHD that they can put the correct procedure together? Sometimes the pediatrician is enough. Often that second evaluation or second opinion is really helpful, especially if it's a complicated or hard-to-decide case.
Mm-hmm. Lots of questions about finding a qualified ADHD professional. A lot of people asking, how do I find one? How can I check a doctor's or professional's credentials to know that this person is an expert on ADHD?
Boy, that's a good question, and often it's by community knowledge and, asking people in the local community, so it's not formally available, and that's a big problem for a lot of us. In our community, what we do is try to have the web descriptions of the clinicians' backgrounds, but other than asking by reputation in the community, I think you can ask the clinician directly, how frequently do they see these cases, and will they have time to provide that 1 to 2 hour evaluation that's needed. This is not the situation where you want to have that 15 or 30-minute evaluation. It's just not enough time to get all the information together.
Mm-hmm. At the end of an evaluation, typically, will a doctor hand the person a prescription for an ADHD medication, or should the professional really evaluate all the data that's come in and then at a second visit perhaps prescribe something?
Yeah, this is a really stylistic question across doctors, and it also depends on the obviousness or obscurity of the case. Occasionally, I have seen experienced clinicians where the family comes in and the picture is very clear. The family is already prepared mentally. They've already gone through a lot of background work, and in that same first evaluation, the doctor and the family will agree to start a medication right then and there. But I think that's the exception rather than the rule. I think the more appropriate usual procedure is for the clinician to get all the information together, formulate the rule-outs and the diagnosis, and then present to the family some treatment options and talk about those with the family. When we look at the best practices for evidence-based medicine, there are three elements that have to be considered. The first is, what is the evidence base for a given treatment? The second is, what is the family's readiness, needs, and preferences? And the third is, what's the appropriate mix of those two things? And so it really requires the clinician and the family to be evaluating together what's the likelihood of medication being successful in the case of this child, what are the drawbacks to that, either in terms of the parent's philosophy, the meaning of it to the child, or other health risks, and how does that compare to other treatment options that exist? We have several behavioral treatments that are available for children with ADHD. There are many times educational interventions that are appropriate or needed. Have those been considered? Have the pros and cons and resources for those treatments been weighed into the mix? And what's the best combination treatment plan for this child? That's the kind of discussion that we like to recommend happen so that the full picture of treatment steps is included.
How long would a typical first evaluation be, and would there be a follow-up to it to allow the professional to sort of analyze and assess the data that he had just taken through history?
Yeah, typically in our clinic, and I think this is true in a lot of clinics, we'll see the family on Monday, and then we'll bring them back the following Monday to go over all the results and to make our recommendations. Sometimes we'll even see the family twice before we do the feedback. That allows us to do a long interview on the first visit, and then to bring the child in and do some time with the child. And then in the third visit, really go over the recommendations, perhaps without the child there, depending on the age of the child. So you really can, get the parents to speak candidly when the child isn't present, really spend time with the whole family and with the child alone, and then have a relaxed discussion with the parents, perhaps without the child present. So often it'll be a separate meeting for the feedback and planning, and I think that's the best way to do it so that the decisions are not rushed.
Right. Once again, the same procedure for adults, would it be, or anything different there?
The principles would be the same. With the adult, you don't have this complication of having to talk privately without the child sometimes. And again, depending on the child's age, you don't always have to talk privately, but sometimes you want to. So with the adult, you might be able to go a little quicker because you might bring the adult in. You might want to interview a spouse or even a parent if that adult is comfortable with that. And then you could have a next meeting to go over the plans.
Okay. One adult who wants to go for an evaluation has some problems. Jan says, it's a real problem for me. The doctor apparently wanted to talk to her mother. Her mother is unavailable. Jan writes, also, given that my behavior is so variable and my ability to monitor it is so questionable, I don't even know how to answer the questions on self-reports. Why can't ADD be diagnosed using performance tests or, better yet, blood tests?
Yes, that's
There's
a great
question in there.
Yeah, but it's a good general question, and I appreciate the insight of this questioner who recognizes that his or her own observations may not be accurate. We can get a lot of information out of the self-report. It's not worthless, even though you feel like your behavior is variable, and even though you're not sure how accurate it is. We can still compare your answers to national averages of people like you who have also tried to answer these questions, so that's still informative. If you can get a peer or a friend or a spouse or a parent to add their opinion, that increases the accuracy. But it would be better if we did have a blood test or a performance test to diagnose ADHD. That's everyone's hope, and that goes back to my original comments about the brain imaging. Everyone wishes for that. The problem is the accuracy is just too low. When we use those tests, we get a 50% error rate. So it can be good ancillary information, and one time when we do put more emphasis on these psychometric tests is when we cannot get that second informant. So in a case like this where there's nobody else to complete a rating, there's no teacher or no spouse or no parent, we've only got the self-report, if we do a laboratory test, it at least gives us another source of information to judge. And so we have, I've done that sometimes where I've thought, well, at least I've got this second source of information that gives me a little more confidence one way or the other. But unfortunately, we just don't have this blood test yet. Maybe someday we will.
Mm-hmm.
I should add, this is not that different from other psychiatric conditions. If you're trying to diagnose depression in an adult or anxiety disorder in an adult, you're very reliant on that adult's ability to self-report their symptoms or the report of a collateral informant. And ADHD in adults is much the same.
Mm-hmm. Beth asks, I know you mentioned brain scans, et cetera, but are psychiatrists beginning to use brain scans to diagnose ADD? And I want to add to that question, would that be a red flag based on your analysis of brain scans?
It certainly would not be standard practice. There are some psychiatrists who are very enthusiastic about brain scans. Some of them are very well known and have published books about their efforts. And these may be clinical geniuses who can get a lot out of these brain scans, but the standard literature does not support this as a diagnostic test that's accurate. It may be that, in the examples I gave earlier, that once in a while as an ancillary test, it can provide some additional information to lend a little more confidence. But by and large, the psychiatrists and the psychologists are not recommending that the primary approach be these brain scans. And if a doctor said, I'm going to use the brain scan and that's going to tell us whether or not you have ADHD, I would say either this is a rare genius who is not in the literature or it's not valid.
Another viewer asks, I know ADHD, ODD, bipolar, and depression can coexist, but that some symptoms of these disorders are part of ADHD. What are the risks of only treating ADHD when there are coexisting diagnoses or symptoms?
That's exactly the right question, and it's part of why this can be so complicated. These symptoms overlap. They can be very confusing, and if we look at clinical errors, I'd say that there are clinical errors in this comorbid area. Clinicians will get distracted by anxiety and overdiagnose anxiety and miss ADHD, or they'll get distracted by the ADHD and they'll miss the depression or the bipolar. So it's really a question of clinical accuracy, but it is risky to identify ADHD and fail to identify the mood disorder or something like that. Now, I will say that in an ambiguous case where you've got comorbidity, say ADHD plus depression, ADHD plus anxiety, I'm going to handle bipolar separately. I'll come to that in a minute. Mm-hmm. But with depression or anxiety, often all of these symptoms will get better when you treat the ADHD. And because the ADHD treatments are often the quickest and the safest, for example, a stimulant medication may give you results in half the time or a quarter of the time of an antidepressant. Sometimes when it's ambiguous, pragmatics may suggest, let's treat the ADHD first and then see what we have left. However, there is a risk that things will get worse if you miss the mood disorder. ADHD medications can make mood worse, can make you more anxious, can make you more dysphoric and depressed. So if you miss the mood disorder, you can actually make it worse by treating the ADHD. So I think it's clearly got to be handled very carefully, and this is one reason why I emphasize the importance of a thorough evaluation that takes enough time to make sure about these comorbidities. And when I've seen cases referred to me who didn't get better in the community treatment, often it was because they did miss the secondary diagnosis. They didn't take enough time. Now, again, maybe not the clinician's fault. Maybe they didn't have enough time. But this is where this comorbidity is so important. Now, bipolar is its own separate issue. We've had a lot of controversy, and you could probably do a whole webinar on the controversy of bipolar versus ADHD. But in brief form, there was a lot of confusion over the last decade and a half in which people who were very irritable, had big explosive anger outbursts, and especially children who had really severe tantrums were being diagnosed as bipolar. And this is because the bipolar criteria used to say that a child could be moody, or irritable. And really it's been a big problem as we saw the bipolar diagnostic rate go up by 1,000% in the last decade in children, and clearly something was wrong there. And in DSM-5, this has really been the reason for modifying the language in ADHD, in bipolar, and adding the category of disruptive mood dysregulation disorder to convey to people that when a child is very irritable and has lots of severe tantrums, that's probably severe ADHD. That child is at higher risk for depression in the future, but they're not at higher risk for bipolar disorder. And so there has been a tendency to over-identify bipolar in people with severe ADHD, especially in children where true bipolar is very rare.
Mm-hmm. In trying to tease out a comorbidity while trying to diagnose ADHD, are there other tests that are normally introduced by doctors to try to arrive at that, either single or twin diagnosis?
Typically, the only thing that the clinician would add would be additional standardized rating measures. Occasionally, we can do psychological testing to tease out a mood disorder, but additional interviewing and additional standardized ratings are the workhorses here for the clinician.
Uh-huh. Yeah. Can you possibly explain a rating scale to our audience? How it
Sure.
works?
The way the rating scales work, they take years to develop when they're done properly. But the good rating scales have very good what we call psychometric qualities, which means that they reproduce well, they're reliable over time. We understand the structure of the items, so we know how they cluster together and how they group together to form scales. And we know the performance in the general population because we've done a good stratified random sample across the whole nation. And so we know, generalizing across race and income level and region of the country and urban and rural, we know, and across sex and age, we know what the general population scores look like. And so we know if the scores we're seeing from this individual are outside the normal range. And this is by itself, we recognize that the rating scales can be wrong and we don't necessarily follow them slavishly, but they really increase our confidence when we see that, in fact, yes, this is over the cut point. Just like when blood pressure is high, we're more confident about hypertension. When this rating scale exceeds our cut point, we're more confident that we probably have a mood disorder or an ADHD on our hands.
Mm-hmm. One viewer asks, can a person, going back to that anger, irritability issue, can a person have ODD and not be ADHD?
Yes, it can happen. It's rare, but it can happen. But I'd say that's unusual. Most of the people with ODD also have ADHD, but there are cases where the person does not have ADHD. They just have anger, defiance, stubbornness, and strong-willed, but they're not necessarily technically ADHD, but it's unusual.
A concerned father asks, I have ADHD, and I know that one of my sons has it as well. My ex-wife refuses to get any treatment for his ADHD, and I was wondering if I should wait to get him evaluated, thinking that he might be better able to handle ADHD as an adult.
Does he say how old he is now? I guess not, huh?
No, he doesn't give an age.
Yeah, this happens a lot, and we've seen it before, especially, and I also didn't say if they were divorced or currently married, but disagreement between the two parents is a common challenge, and we see this quite frequently where one parent wants to see some treatment for ADHD or an evaluation. The other parent really doesn't. This is often an issue of philosophical differences between the parents, and if possible, the best thing is for those two parents to go and see a counselor together, maybe even without the child if they can't agree to involve the child, and really talk through the philosophical and the parenting concerns, because sometimes there's a little bit of wisdom in both parents here, and the clinician can help to sort this out and help the parents figure out, given what you're saying in this case, I think your higher risk is to do nothing, or your higher risk is to do something, because usually the parent who's opposed is concerned about the risks of doing an evaluation. They're concerned about false labeling and so on. And these risks can often be protected against if the clinician understands the parent concerns. And you can explain it to the child in a certain way. You can keep the control with the parent. You can agree ahead of time that you're not going to take the control away and force a treatment that one parent doesn't agree with. And typically, if you don't have two parents agree, it's foolish to try to undertake a treatment regimen because it's not going to succeed anyway without parent support. But I would advise in a case like this that the two parents agree to see somebody to help reach an agreement, because getting this right is important, and perhaps both parents have a valid point to make.
Very sort of a technical question. Who should an adult with ADHD see for a diagnosis? Does he start with his doctor? Is there anyone special he or she should go to?
They could start with their own doctor, ask the doctor if there's any medical reason for the problems, and then I would ask the doctor for a referral to somebody who can conduct a full ADHD evaluation, a psychologist or psychiatrist who does this for a living, and ask for that second opinion, just like you would if you had a sleep problem or an endocrine problem. You get a referral to the specialist and get that consult. I would ask your doctor for that second opinion consult.
Do specialists ever or professionals ever use an IQ test in an evaluation for ADHD?
Yes, we frequently do. Again, not as diagnostic, but as ancillary information. And there are several reasons for that. If the IQ is below average, this may explain why school is hard. And it may also, the IQ test can reveal the learning style and can help us see that, well, this individual really is a nonverbal learner or a verbal learner, and that explains why they're struggling in these particular areas. Or this individual really is not doing well with abstract. They really need these specific examples to learn, and this is part of their cognitive development. So it really helps capture the cognitive development in a way that can explain the problem. And furthermore, it can help us see if the attention problems are out of line with the overall cognitive development. And again, this is not diagnostic, but it's another clue to help the clinician decide, the attention is the one thing they really can't do and everything else is normal. That adds even more confidence when you're otherwise not sure about the diagnosis.
Are IQ tests ever used with adults who might be, supremely challenged at the job or have some other challenges? Yes? Absolutely.
The IQ tests are helpful with adults for the same reasons. They're particularly helpful, for example, say you have a college student or an adult who's in a very demanding profession and they're struggling. Maybe they're a very talented person who's not cognitively in the best setting. Maybe it's not a good fit for their cognitive style or cognitive strengths. On the other hand, maybe they're a very intelligent person who's not being sufficiently challenged and they're bored. And we do see this occasionally where a gifted individual is having trouble engaging in material that's too easy. This is unusual, but once in a while we actually recommend that the child's academic task be increased rather than decreased because they're not getting enough challenge. Often it's more a question of changing the content to make it more suitable to that individual's strengths. But for adults who are having occupational challenges, the IQ test can help flesh out the picture of the match between the occupational demands and the cognitive strengths, and to say, this is not playing to your strengths, that's why you're frustrated, but it's not really ADHD, or in fact, the cognitive doesn't explain this really looks like ADHD.
Mm-hmm. And how does one assess or evaluate for learning disabilities while evaluating for ADHD? Is that a separate challenge?
Yes. Again, you want to bring in a psychologist, and you have to do psychological testing, and this would include IQ testing, testing of academic performance at minimum, and often additional neuropsychological tests to evaluate things like executive functioning, verbal memory, nonverbal learning, and so on. For children, and especially where resources and money are a concern, often the school can provide the basic IQ and educational testing and provide a look at whether there's an obvious learning disability there. Sometimes that's not satisfactory either because the school got ambiguous scores or the cognitive problems are fairly complicated and you really need a full neuropsychological evaluation to get that whole picture in front of you. Or in the case of an adult, there's not a school available, and so you have to go to a neuropsychologist or a psychologist. But one way or the other, you need a psychological testing to be done. If you come to a psychologist for the ADHD evaluation, typically they will conduct that testing automatically because that cognitive profile is a big part of the service they can provide, regardless of the diagnostic picture.
This one I'm not sure it comes out of left field or not, but this person says, I'm an adult who has been medication resistant, having tried nearly every ADHD medication appropriate for inattentive type. Can you elaborate more on metabolic testing? I think you might have mentioned that in the beginning. in terms of ruling out physical conditions, but this is in relation to medication.
Yeah, that's right. The metabolic testing would not tell you why the medication didn't work, but it could identify another condition. And again, I'll use the example of a thyroid condition. If this hasn't been ruled out, the ADHD medication probably wouldn't work. You would need a thyroid treatment. And one could identify a number of other similar conditions that might mimic ADHD. These aren't very common, but when you've begun to fail in every other treatment, maybe their probability goes up. Maybe you want to take them more seriously and go and get that evaluation done and ask to see if your GP isn't confident about this, ask for referral to an endocrine specialist and ask for a full evaluation of other conditions. If this is inattentive ADD and the person is low energy, you've also got to look at nutrient imbalances and at sleep problems. And often that nutrient evaluation is not part of standard workup, and you might have to ask the doctor for a referral to a dietitian or a nutrient specialist to make sure that you're getting, or just additional blood work to make sure you're getting adequate nutrition. Iron deficiency, etc. There's a number of possibilities here.
I see. Does the public school system offer evaluations? And there's a follow-up. Is there insurance coverage for any of the evaluations, assuming you have to do it privately?
As far as the schools, they will typically provide the learning evaluation, IQ, and education. They usually are not equipped to provide the full ADHD evaluation. So what we see is that the school will conduct their learning evaluation. They'll not be confident that they've identified the problem, and they'll advise that ADHD be evaluated, and then they'll ask the parent to go and get an ADHD evaluation in the community. Occasionally a school will go ahead and designate a child as ADHD, but that's very rare without a physician, psychiatrist, or psychologist providing that in the community. The rare school has the expertise to do it, so I would say typically you have to go into the community to get that ADHD part of it. There is usually insurance coverage. The evaluations we conduct have always gotten insurance reimbursement for the family if insurance is available. So I would say typically this is going to be covered by insurance if you have insurance.
Mm-hmm. Do you ever find there might be a challenge also in terms of parents who might be frustrated or challenged, who might push for an ADHD diagnosis as they're sitting there because they want to be able to take control of their child's symptoms as soon as possible or find a name for it? Is there ever any kind of pressure from the parents to try to get that diagnosis?
Yeah, I would say it's common for a parent to have strong feelings one way or the other. They really hope there is or is not a given diagnosis. Some parents want it to be ADHD, some don't want it to be ADHD, some want it to be autism spectrum, some don't want it to be that. So parents often come in with a wish for what it will be, but every parent I've talked to ultimately wants the right answer. And so that pressure I've never experienced it as a serious obstacle to getting to where we need to get to. It's often a starting point that requires some discussion, and I always encourage parents to keep an open mind. This is why you're getting a professional opinion. The self-diagnosis just isn't very accurate, and it's important to understand why you feel strongly about this. Why do you want it to be ADHD? Often it's exactly, Wayne, what you said, that clarity is so helpful to get a way forward. And many parents are frustrated because they've been given one ambiguous conclusion after another, and they just want some clarity. And that's a very understandable desire, and I think the clinicians ought to be able to give that.
Mm-hmm. Let's say the professional, after doing the history and do all the appropriate testing, says that the child or adult has ADHD. Should the patient not necessarily push back, but ask questions about why or how he arrived at that?
Absolutely. I think you should ask, what makes the clinician convinced? Why do they think it's not something else? Is there anything the clinician feels is ambiguous about this? Or because often the clinician has to make a judgment here on the probabilities, and what I've often told parents is, the most likely answer here is ADHD. I think it's what we should go with. But there's a slight chance that we're wrong, and here's why. And here's what we're going to be looking for going forward. help us know if we're wrong. So we can sort of start with the ADHD is the probable diagnosis. We're going to treat it accordingly. But if the following occurs, we're going to guess that we're wrong. It's kind of like the analogy of, you took your medicine for your flu or you had your surgery, but if the following happens, then we know it didn't work. Call the doctor right away. It's kind of the same thing with ADHD. If the following occurs, then that tells me that we made a mistake and we need to make a change. And so the parent and the clinician can be partners in that way, where the parent is empowered by the clinician to be looking for certain signs that the clinician can tell them about that will tell them we're on the right track or we're not on the right track. One of the most common points of confusion here is that when you start a behavioral intervention for ADHD, things will typically get worse at the beginning because the child is going to test that new behavioral intervention. And this people often give up at that point right when they are actually on the right track. So that kind of prediction by the clinician can really help the parent to know what's supposed to happen.
Mm-hmm. Debbie asks, where is the best place to begin seeking an ADHD diagnosis? A school psychologist, a pediatrician, a private therapist / psychologist?
I would say all three could work. I would probably start by talking both to your pediatrician, ask them if they think it's possible, if they think there's an obvious medical explanation, and then talk to your school and ask the teacher point blank, level with me. Is my child extreme here? Are they out of the ordinary? If your teacher says, yeah, your child is one of the 3 or 4 in the class that's really, on the edge of the spectrum here, that's a pretty good sign that you should get a full evaluation. If the teacher says your child's right in the middle of the pack, I don't see any special problems, then that's going to be something else must be going on. That's going to be a very serious caution. But I think if you talk to your school teacher, ask them to really give you the straight story and what they see, listen hard to what they're saying, talk to your pediatrician, you're going to have a pretty good starting point for knowing if you should go after that ADHD full evaluation.
Mm-hmm. An adult asks, do you especially like a particular free screening tool? I think he might be talking about online tests and quizzes.
Yeah, there are some online that are good. Probably the best one I would say would be the Strengths and Difficulties questionnaire. If you Google SDQ or Strengths and Difficulties questionnaire, you can self-administer and self-score online for free, and it's got excellent norms. So that's if you're going to do self-screen, that'd be the one I would pick. And because it has an ADHD scale, but it's also got a scale for mood problems and for other problems, so you can get that rule-out aspect in there as well. That said, I would really urge caution in self-diagnosis because there's a laundry list of mimic conditions that you can miss. But certainly if you're going to do a self-check and just say, where do I stand, I would start with that one.
Mm-hmm. One person asks, does ADHD mask depression, and does depression mask ADHD in terms of evaluation and diagnosis?
We don't use the term mask anymore, but in essence, the answer is yes. These two things can mimic each other. A depressed person can look very inattentive, and an ADHD person can look very low energy and very discouraged and seem depressed. And so it's an important differential diagnosis to evaluate depression. So I would say the answer is yes. The clinician has to separate these two things very carefully.
Mm-hmm. As with physical diseases, is it ever worth getting a second opinion?
Yes, it is. Worth getting a second opinion, I would think, in two instances. One is when treatment didn't work, then the second opinion, of course, is very valuable. And most of what we do in our clinic is second opinions for that reason. We see cases where the treatment didn't work and the clinician wants another opinion, or the parent does. But the other place where a second opinion is valuable is just when there's not agreement. When I talk to parents, I typically will lay out my formulation of the child and the ADHD, which, if it is or isn't ADHD, if that parent is saying to me, this fits perfectly, everything makes sense to us now, I feel then I think we're on a better track. If the parent says, I don't understand, this doesn't feel right, then I might want to get a second opinion. Or if I, as a clinician, feel like this case is so ambiguous, I have a high probability of making an error, I'm going to get a second opinion. And so I think the second opinions come in when you can't get agreement among all the parties. The clinician, the parents cannot see eye to eye, or the two parents in the earlier questionnaire asked, two parents don't agree. I think a second opinion can be very helpful in resolving it, just as in a physical case.
I think this will be the last question. Ray from Florida asks, where can I go to have an ADHD and cognitive evaluation done for my 13-year-old son that is affordable and reliable? We've had 2 ADHD tests, in quotes, done, mostly questions and the TOVA, but I want to be able to be sure that it's ADHD.
Yeah,
I guess it's the affordability.
Yeah, affordability. If affordability is an issue and insurance is limited, one option is to go to a university clinic, depending on where they are in Florida. Florida has 2 or 3 major universities with great ADHD programs. And so if you go to the universities, often you can get to their training clinics, and you'll see a trainee supervised by a very experienced expert at a very low cost, and that can be a great solution. Most of the major universities in the country with clinical psychology programs, for example, will do this, as well as many of the good psychiatry training programs. And you can see a psychology doctoral trainee, or you can see a psychiatry resident at a reduced fee because it's a training experience for them. But your supervisor, the faculty supervisor, takes responsibility and has lots of expertise, and you end up getting often just as good, if not better, of an evaluation because you've got the enthusiasm of the trainee who's turning over every possible stone, combined with the experience of that supervisor. It can work out quite well. So if cost is an issue and you want a thorough evaluation, I might start by calling some of the universities.
Good advice.
And Florida's got several very good ones.
Yeah, do you want to name just 2 off the top of your head? Do you know them?
Well, Florida State, University of Florida, and University of Miami all have good programs.
Oh, okay.
And Florida International University does as well, so that's 4 right there.
Okay, well, thank you very much, Dr. Nigg, for your time and expertise. It really was enlightening.
My pleasure, and best of luck to everybody who listened.
Thank you. Have a good day, everyone.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com.